We're back. We're back, and there's nothing like a short commercial. It's one of the things that anybody that's watching video content with me will tell you. I don't like long commercials. So we appreciate that. Now we're going to bring up our panelists. You have seen their bios. We're working in a multifaceted environment here. So some of the things you see, I can't see. Some of the things I see, you can't see. But my understanding is that you have seen the bios. And so I will introduce our panelists and let them speak some more specifically about themselves, because I don't have their bios in front of me. The first panelist that I will bring up would be Miss Sheri Dawson. And she is in a very prominent position in the government related to mental health and mental health issues. I'll let her talk more specifically about that. And then Elisa Palmer, her name always rings in a way that makes me want to mispronounce it. So I will bring her up. Also, we have been operating in the community in a similar fashion. Actually, attended the same school to some extent and is operated in the same field. So we've never worked together, Elisa, but I have seen her work and heard of her work and met her when she was in the developmental stages of what she is now doing to the max. So she told me a long time ago that she was going to be doing these things, and now here she is. So Ms. Dawson, if you could, I know you was telling us that it could be potentially a issue with the lights going out in your building. So I see that you have already entered into the darkness. I'm in my work building also, and I'm hoping that no lights go off, because if lights go off in here, it's going to be a problem. So I know that you are in a executive position with Department of Health and Human Services.
Yes.
And if you would tell us exactly what it is that you do and give us an introduction to yourself, I'd appreciate it.
You bet. Thank you. Thank you, Larry. And to just the planning committee for this opportunity. My name is Sheri Dawson, and I happen to be a registered nurse by training for 39 years. So healthcare is very near and dear to me. When I was a child in elementary school, I was a child that experienced stomach aches, and was afraid of crowds, didn't want to go to school. And so at a very early age, I had life experience with anxiety and depression. And I will say ever since that time, it's probably been, between nursing and my lived experience, a calling. So I serve as the director of the Division of Behavioral Health here in the Department of Health and Human Services. Many in the area may know that our division works with our system partners. We have 6 behavioral health regions across the state. Region 6 is in that community. And our funding is really intended to meet individuals that fall in between Medicaid eligibility and people that don't have insurance.
Yeah.
And so I want to start the message, Larry, with I believe there is no health without behavioral health. And I think these forums help all of us in healthcare because behavioral health should be a strong part of that. And we have to acknowledge and just start the conversation by acknowledging the inequities that we experience, that individuals that are Black in our society experience racism. And unless and until our system continues to work together to identify, to address and acknowledge racism and inequities and the trauma and how people experience that, we will not be as far along as we need to be as partners.
I would agree. I would agree. Thank you so much for that introduction. Elisa,
Yes.
feel free to introduce yourself.
Yes. So I am Elisa Palmer, and I am a therapist over at Heartland Family Services.
Mhm.
Heartland Family Services offers an array of behavioral health services, very similar to those that you've talked about that Charles Drew do. We're a community partner. My specific role is I am an in-home therapist. And so that's a little different than many of the therapists right now. For the last 3 years, I've been in the in-home program, specifically going into home, providing therapeutic services to families in crisis and their children, doing evaluations, referrals, and some of the clients retaining for myself. Majority of the clients that I do see are North and South Omaha populations,
Mhm.
below the poverty guideline, or living in subsidized housing, low income housing. So when you see me, I'm going to be looking like this, very casual. I don't have no nice office. I do
Okay.
get some clients in office, but 90% of my job is in the field, even during COVID.
Right.
Outside of family and children, I also get to see some with disabilities, but I see my population is majority African American or people of color.
Okay. Well, that's when I came to Omaha, and then I started in the field. That's how I started. I started as an in-home therapist, and early 2000s. I was with Dr. White, and so some of the people out in the community who are listening to us tonight will remember Dr. White. He was one of the first individuals who developed the whole idea of in-home therapy, and there's some reasons for that, as far as why that was a approach that was necessary and vital in our communities. Okay, so let's just get started. Mr. Saunders gave a real good idea of, some of the issues with mental health. He gave it from a broad standpoint, gave the big global picture, then he drilled down some in terms of people of color, Black people in the local area. So is there anything that you would like to add, or anything that was particularly highlighted for you, and anything that he shared? So just to kind of connect with what he said, is there anything that you'd like to say in combination with him, maybe to further what he said, or to just pick up from there? Feel free to speak for you. Everybody's unmuted, so just whoever speaks, somebody else can speak second.
You want to go first, or I can go? I'll jump in. I'm a talker, so you give me a church finger and I'll stop.
Okay.
Go. But I will say that when we talk about people of color and people in our community, he was right. There is a lack of individuals that seek our services. And I would like to highlight and speak specifically to our African American men in our community, that they just don't, they're very reluctant to receive the services. We don't have a lot of therapists in our community that look like us, and the ones that we do have that look like us, they are just swamped. I mean, we have more clients than we have therapists that are available. And then if he talked about psychiatrists in the communities and in our community of Nebraska, just to get into any psychiatrist is a 90-day wait at a minimum. So you add on top of that they may want to talk to someone that looks like them. They could work for 6 months to a year for a wait to get a psychiatrist that looks. So I just want to highlight that, because I want to make sure we speak it specifically in regards to our community and some of the barriers that lie in front of us. I can go in a home, but if I don't have nowhere to send somebody for someone that looks like us, then I'm having a hard time, more clients than I could ever see.
So the barrier of resources is a major barrier. From what I hear you saying. Then when you look at all of the various dynamics that go along with that, folks who are trained, people who are providing services, people, whatever stigma or thoughts about that is in the background, all those things only compound it and make it worse. Sheri, did you want to add anything to the initial introduction thoughts?
I would just add, totally agree. with the workforce in general. That is, as she pointed out, short in general. And then if we do look at having individuals that are look like us, understand our culture, and even those that are trained and in the workforce right now, there are providers that do an excellent job of understanding trauma and putting out on the table and asking to build that trust and take that time to establish that relationship, which is challenging for anyone in behavioral health. And then, as Alicia pointed out, within the Black community. And so if they go to a therapist that perhaps is more about getting the diagnosis and treatment, that leaves a lot out, right, for that opportunity to build that trust and relationship. Raheem talked just a little bit about adverse experiences and youth and children. And I think that is a really important concept, the adverse child experiences.
Yes.
And we know the variables of adverse events. And the more of the experiences and events that children experience, we know as adults, depending upon how that is addressed or not addressed, is going to, they're going to be at high risk for both physical and behavioral health, which brings us back to the continuum and that opportunity to get into the prevention and early intervention and in the home that you talked about.
And that's the term ACEs is a very good acronym for the work that's done in that area. So when we break it down and just look at it real simply, that we can assess the type of events, the issues, the problems, the trauma. I think about trauma, I try to frame it in a way that the audience can understand it. Things happening to kids physically, psychologically, emotionally that they're not equipped to handle. They're too young. They're not developed enough. It's over. And so therefore it's too much for them. Those kinds of experiences, the more that they have, the earlier that they have them, and the combination of them, we can assess that early and it will speak to the conditions they will have later, medical conditions they will have later, and specifically psychological, psychiatric issues that they will have later in life. So that's pretty major. All right. So when we talk about mental health, we know that mental health in general, and I'll put it like this, when an individual has to some extent lost control of their mind. So they're hearing things, seeing things, they're under mental distress. And so some of the things that are more, I would say, severe and persistent, to use the exact terminology, we clearly understand what that is. We know what that looks like when we see it. We know what that sounds like when it's speaking. So we know what that is in general. When you, from your experience and working in the field of mental health, what type of unique things are unique to Elisa, people of color related to mental health that perhaps goes beyond the things that we traditionally think of that I just mentioned in terms of a more extreme example. So when you talk about someone in the street, walking down the street, talking to themselves and all those kinds of things, well, yes, we all know what that is. We don't really need to have a conference to know that there's something really mentally wrong with that person. But is that all of what mental health is?
Of course not.
Is that so when we give those descriptions, we just okay, that's what it is. Then we might as well just wrap it up and pull down the shades, because I think everybody know that. So how can we dig deeper into what mental health is from your perspective? How do you see what is mental health, and what are the issues mental health related that affect people of color, Elisa?
Ooh, that's a fully loaded question. I'm laughing.
Yes, it is. That's what we do.
Let me put my coffee cup down. The stigma around, first of all, let's talk about just the stigma around mental health for people of color is from generations. It wasn't that African Americans didn't want help or didn't have mental health problems.
Okay.
It was more, if we could go back to slavery, we were conditioned not to ask for help. We were conditioned to be quiet, not to talk about those things. We were conditioned to always be strong and walk around with our S on our chest. So we have that image that we are strong, we are resilient. So the stigma is for us to seek mental health services, it makes us look weak. And so when we are having that life-changing situations, as I do trauma-informed care, trauma, I call them life-changing situations. That death in the family, that we lose someone to gun violence in our community, or so we've lost someone unexpectedly to COVID, these life-changing situations that may go on. We don't get that, our first avenue is, go talk to someone that is trained and has been trained to deal with individuals that's going through grief. Our first stop normally in an African American family is to go to our churches and our spiritual sources, and not taking anything from a pastor or a church or any religious organization. Yes, that is a great resource and a great support system when you're dealing with depression and anxiety symptoms. But when you have a disorder of anxiety and depression, and that means you have symptoms that happen on a frequency daily or nearly every day, or more than 14 days out of 30 days in a month, then those are having times where you need to seek a healthcare professional that happens to be credentialed in mental health. Can even make a referral to you for a psychiatrist that can prescribe you some medications to assist in those areas. And so that's a long process that African Americans oftentimes don't even have the time for. African Americans in our community, and we're going to talk just about our people of color right now. That's my focus. But they're working 2 or 3 jobs to maintain a family. They have they have 2 or 3 children in the home. To get these services and these appointments scheduled, it's Monday through Friday, 9 to 4. 4 o'clock, probably the latest time you're going to get a therapist appointment in our community, and these individuals are working. So to just reiterate that these are things, it is some systematic racism things that fall into place that lead to barriers why African Americans are not seeking those services. We can talk about just in our school system and the services being available. And it's great that there are therapists that are in these schools now that Charles Drew is having available. But when we talk about the student to therapist ratio and the availability, if you have a central high school that has 1,000 students and 10% of them need to see a therapist. That's just hypothetically speaking. 10% need to see a therapist, but we got one therapist or maybe 2 therapists that fills one 40-hour-a-week role. How many students can they see in that time? I just, I like to put numbers and make it realistic. And that's the thing they talk about, that schools are the first, outside of the home, the school is probably the first place that someone's going to get those, that even the light shined on them, that a therapeutic service is needed either for that child, that parent, or that family as a whole. That's where most of my cases come from.
Yes. The overall information says that in terms of mental health issues as a whole, mental health issues are occurring for the American population about at the same percentage. So we're not having more, we're not having less, they're somewhere within the same percentage. However, how we are accessing as Black people, how we're accessing that care and the chronic nature of some of the things that we deal with, it's different in that respect. I think, Sheri, you are in a unique position from the standpoint that as a nurse, you've worked with people and as I would say, on the front lines. And then as a executive, if I could use that word, you're seeing the bigger picture. And as for far as I can see, it's a little dark, but as far as I can see, you seem to be of European descent, if I could put it that way. So I think all that gives you a unique perspective to say to us, how do you see the issues when you look at from your whatever your experience has been and how you how you positioned now, how do you see issues in our community as different from the population as a whole, or do you see it different? And I want you to feel free to answer that and as genuine as you can, because it's an opportunity for us to get your perspective on it, as well as to give you our perspective.
Yes, and Larry, thank you. And I hope that it's the latter, because I certainly will share my perspective, experiences, and information. But I'm also here to learn and to be able to get us to access this, Raheem. So I will look forward to that. I would just say, again, if we think about recovery just across anyone that's experiencing a mental health or substance use disorder, there are tenets to recovery. Home, having a stable place to live, your health, physical, behavioral health, community, that there's natural connections, relationships, and supports, and purpose, which could be education or a job. With COVID, what of those have been impacted? Absolutely all four of those.
Yes.
Sometimes people, we call those social determinants of health.
Yes.
So in order for you to be well or healthy, you have to have that full home health community purpose to help move the journey forward. I know in looking at the data for, Raheem talked about some in terms of access. I would say that the percentage that we have experienced in Nebraska looking at race is about 7% for young people with substance use.
Right.
11% for those 12 and over, and about 43% for adults and children with mental illness.
Wow.
We have disparities in the Black community. We have experienced, I will say, barriers, natural barriers, because as Alicia pointed out, we also don't have access where it always should be, right?
Yeah.
So again, trying to think about those disparities, and I want to get to solutions in a way that we absolutely acknowledge workforce challenges and where we serve people. If faith communities are absolutely one of the strongest places that individuals in the Black community go, how can we think about our service location rather than being in a clinic, or to Alicia's credit, in the home? Where are people going? If they're going to the food pantry, if they're going to the job location, if they're going to church, if they're, we have absolutely got to make access easier. And part of that is listening and learning from you all about what that looks like, because place matters.
Absolutely.
It should not be the case that where you live determines how long you live.
We and Elisa can speak for herself. So just to summarize this up, because I think we're somewhere getting close to another commercial time. But you know, we believe that some of the barriers and limitation to disparities, to some extent, is intentional. That is kind of the definition of systemic racism and like that. So when you look at these are problems. And then we say, okay, yeah, these are problems. We can all see that these are problems. People are not getting access. The access is not really available, et cetera, et cetera. Let's work on that. And so we work on that. And then X amount of years later, the problems are still there. Then at some point, okay, this must be intentional. It's same way with some of the things having to do with policing, which is a whole nother topic for another day, is if we identify this is a problem, you're using excessive force, and then we put a lot of attention on it. There's a lot of outpouring and whatever, and then it's X amount of years later, it's still happening. Okay, then this is on purpose. So you look for the standpoint to speak to. I like you see, did you see her weave in the recovery model in there, Elisa? She weaved it all in. She had the whole wheel
She
of
did
recovery.
it. She did it. I like
She did that beautifully. So I like how you pointed that out. So we look at, for instance, schools.
Yep.
And the whole idea of purpose. Purpose saying that children need to have a sense of identity. They need to have a sense of who they are in the world. They need to have a sense of their worth and their value. And a primary place that they're going to get that, of course, is home. If the home is disrupted in any way, then the biggest backup to that is going to be school. So if in school, for instance, we understand that that's the biggest place where this information and build up and edification of youth is going to take place. This is who you are. This is where you're from. This is how you got here. This is what you got to deal with. You see what I mean? If they're going to get that, then it's going to have to be some history taught. There's going to have to be some critical, real history involved in school that's going to elevate their sense of esteem, elevate their sense of purpose, elevate the sense of who I am as a child, which will also research has said that ethnic related background environments of education raises the scores and lowers unwanted behavior. So that's a protective factor. But it would take, you'd have to move a mountain and slay Goliath to get real, true African-American history. When I say the history and the connection of Africa and America in the school, so the kids will have some understanding of who they are prior to slavery, and slavery not even being dealt with in a real way, but that's not the beginning and end of who they are in the world. But that there is a great resistance to that. So that's intentional. So if there's disparities, and I think we have to continue to work on those disparities, then to some extent, the thought would be that's intentional. So what has improved? What has gotten better? So from my standpoint, definitely dealing with the funding and Region 6, as you mentioned, and the regions being brought down. There's no one that can come here to a federally qualified health center, which Charles Drew is, and be turned away from services. And that is greatly supported by the funds that come from the Department of Health and Human Services. That is consistent. It's not going up and down. It's not wavering. So we can say that people come here that don't have anything, they can still get services for themselves and for their children. Medicaid has been expanded. So, and we're seeing more people on the rolls there. So the funding is improved. That's in a sense of improvement. There are they're in my ear, so I pause for a moment. The funding for to provide more therapists, that's increased too. There's programs that are available to train and treat other people. So briefly, give us a short idea of what you think is improved in regards to that, and what's working for our communities in regards to mental health. And then we'll go to break.
Go ahead, Ms. Sheri. I went first last time.
Okay. Well, I think one of the other things that has increased is the recognition of the whole continuum. So we got to get out front. It's great that, there are some services when people are experiencing crisis, but you talked about the young people, Larry, and having prevention, substance use prevention early, early on, thinking about early childhood and wellness and looking at some of the other activities that are more education based to help improve the health of individuals. I think since the time I have been a nurse, I can't even tell you that prevention was even taught when I was in nursing school. It was all about once you get to the point of
Right.
impairment.
Yes. Yes.
Stigma and awareness, I think, is the other thing. We're having this conversation tonight. As you pointed out earlier, opioid crisis,
Mhm.
COVID disparities. There are a number of things, unfortunately, bubbling up. And yet there is still a reduction in stigma. Again, if I look back over time, even my time here.
Yeah, I would agree.
It's
Lisa?
not where it needs to be, though.
Yes, there is a reduction, but there's still more more journey to go.
I would say for an area of improvement or that we're seeing movement in Nebraska, in our Omaha community, is that we have taken an approach of trauma focused and trauma care, which is very important, especially for our people of color. And people are being trained specifically to focus on that and be more empathetic. I think Rashid talked about that at the beginning, about being more empathetic as one of our benefits that we do have that's available along with that funding. But that trauma-informed focused care and trauma-informed focused cognitive behavioral therapeutic services that are available and coming more available now is important. We do have more of a presence of our African-American therapists and health professionals that are starting to say, hey, let's get this list together and let's share the wealth, because and I think that's a benefit that I have seen. Oftentimes you see like everyone was kind of like, I don't know no other African-American therapists, but now we are in positions where we are connecting the dots for the other individuals in our community. And if that's not my area of expertise,
Right.
I acknowledge that's not my area of expertise. And I'm sending them in the direction of other individuals that can help them. So I just want to say that, that trauma-informed focus, that trauma-focused care is very important in our people of color community, because it addresses those things of that gun violence that goes on in our community. It addresses in Nebraska that 3 degrees of separation, because not only is the gun violence happening to my son, but maybe it's his friend that happens to be his uncle's brother, cousin, and they know each other. They all go to school together, and the aunt work with the mama.
Only in Omaha.
Only,
I don't think so, but yeah, I bet it does.
Not only in Omaha, but I mean, when we talk about, we talking about Omaha tonight. We talking about Nebraska. We talking about what needs to be done for people of color in our community right now.
Yeah.
And this is just the reality of it.
Yeah, I was just talking about the closeness and how one person is related to another person is related to another person. So they're in my ear. We got to go commercial. We have taken to, just for our audience tonight, we've given you a picture of what mental health is in general and specific to our communities. We talked about some of the disparities, most of which I'm sure you are aware of. When we come back, we want to dig more into this whole issue of trauma and what that's really all about. What are the differences in terms of trauma from community to community? Is it the same, or are there some unique things for people of color? So at this point, we will take a break.